Okay, so today we're going to talk about the evolution of the treatment paradigm in EGFR mutated metastatic non-small cell lung cancer. And before we get into it, I just want to, tell you a couple of interesting cases um, as to how revolutionary these EGFR inhibitors are, right? So I'd like to talk about two cases. The first case is um, when I was in Lucknow. So there was a patient from Bihar. I think he was around 35 years old, and they bought him in a stretcher actually. So he was bedridden, with diffuse meds all around the body, and and they didn't have any money to do any sort of investigation or nothing. They didn't have access to the government documents. So they came to us and they said, when we asked them to do all these investigations, they said it's not possible for us. So, we happened to have some Jeftinib lying around and said, okay, let him get some benefit if he has some EGFR mutation. And we gave him, 2 months worth of Jeftinib. And 2 months later, someone came, a fellow walked in, sat down, and when his file came in front of me, I was like, this is that performance 4 patient. So within 2 months, almost all his disease had been wiped out with just Jeftinib. So that just shows you, just a simple tablet can have that effect. Then there's another case. This was an army colonel. So he was admitted in the ICU and he was put on a ventilator. He had diffuse bilateral lung mets, and his pulmonary capacity was very poor. And it looked like it was lung cancer, and we did find that it was EGFR exon 19 mutated. And so it didn't look like anything would happen. It looked like he was going to meet his end. But they had the funds, so we just started him on osimertinib through a Ryle's tube. And slowly but surely, over a period of 2 to 3 weeks, his condition improved. And the guy that was mechanically ventilated walked out of the hospital after 1 month. So that's another story, those are the sort of stories and experiences that, made me passionate about lung cancer, especially, driver mutated lung cancer. So enough about all that. Let's get right into it. So let's look at the prevalence of EGFR mutations, right? I think that's very important. So the prevalence is around, it varies from region to region. So 40 to 50% in Asia. And if you look at in Caucasians, right, it's only 10 to 15%. So this is why we need to know this in depth, because it is 3 to 4 times more prevalent amongst the Asian population, which includes both the Indian subcontinent and Oriental. So it is highly prevalent as compared to the Western world. So this is something that we are going to encounter, and we have already encountered on a regular basis in our OPDs. So the EGFR pathway, right? So you have an EGFR receptor, right? It's the cell membrane. The EGFR receptor has got an extracellular domain, transmembrane domain, and an intracellular domain, right? So when this is activated, two downstream pathways are activated. The RAS-RAF, also called the MAP kinase pathway, and the PIK3CA-AKT pathway. I won't get into the specifics of these pathways, but that's generally how they get, once you activate the EGFR receptor, which has all this extracellular, transmembrane, and intracellular domain, both these two downstream pathways are activated, and that's how the EGFR receptor, enacts its mechanism of action. And generally, EGFR is needed for cell growth, especially in the epithelial surfaces. It's you need it for a normal functioning human being. But there are certain mutations, right, that can occur, which lead to lung cancer. So what are those mutations? So in the intracellular domain, you have exon 18, 19, 20, and 21. This is of specific interest to us because the mutations in those exons of the intracellular domain are what are what cause lung cancer, right? EGFR mutated lung cancer. So the most common one seen in 45% is exon 19 deletion. Exon 19 deletion. I'll just talk at the end. We'll have a question and answer session. So 45% exon 19 deletion. Then in exon 21, we have a substitution mutation, L8, L858R, right, in exon 21. And that makes up around 40% of the cases. So these are the two most common mutations, and most of the trials for EGFR inhibitors revolve around these two mutations. So that's number one. Number two. Number three is an exon 20. That's the exon 20 insertion mutations. Okay, so the exon 20 insertion mutations. And four, we have some rare mutations. This includes G719X mutations on exon 18. It includes the S768I on exon 20 and the L861Q on exon 21. I mean, don't keep all this in your head. Just remember, these are the common ones: exon 19 deletion, L858R substitution. That's second most common. Third most common is exon 20 insertion in 9 to 11%. Just remember the common ones. Know that there are some rare ones as well. So now you've got a patient of EGFR mutation. Now, these are practical things that you need to know. What is the ideal biopsy site, right? Because, should we biopsy the metastatic lesion? Should we biopsy the primary lesion? So what is the ideal biopsy site? So the ideal biopsy site is any site that is convenient. And why do we say that? The fact is that no matter what site you biopsy, there's a high concordance in a newly diagnosed patient of EGFR mutated lung cancer. So if you diagnose the metastatic site or the primary site, it doesn't matter as long as it's safe, as long as it's accessible. And this is what the NCCN says as well. So the easily accessible site is what you biopsy, which is safer for the patient because there's no there's no disparity between the metastatic and primary site when it comes to detecting these mutations. Now coming to the testing technique. So earlier we used to have PCR. PCR was the way to go for detecting EGFR mutations. But currently we use next generation sequencing, right? And we do it as part of a broader panel of next generation sequencing. And we test for other driver mutations like ALK, ROS, BRAF, RET, MET, HER2, KRAS, so on and so forth, right? So there are two ways. This is another concept that I want to get across. There are two types of NGS that we use. So we have something that's used for experimental studies like whole genome sequencing, whole exome sequencing. But in our clinical practice, we use something called targeted NGS. Now, targeted NGS, as you can see on the screen, is of two types: amplicon-based and hybrid capture method. I'll probably take a different class on this, but amplicon-based, what you need to remember is it is more focused, so it can only detect a set number of genes, right? So it's known as hotspot testing. Whereas hybrid capture method, it can detect a larger, wider array of genes. So, for example, for amplicon-based method is what we commonly use. We use something called the Pulmocore 12 gene panel, which detects the 12 most common driver mutations. An example of hybrid capture method is your foundation CDX testing, which tests for 302 genes. So generally in our setting, we tend to go for amplicon-based hotspot method, detect only those commonly seen driver mutations. So EGFR is done as a part of that, and we generally tend to use hotspot-based, amplicon-based method of NGS for EGFR testing. It is more focused and targeted on a set number of genes rather than hybrid capture, which detects a larger gene pool and takes a lot more time actually for the results to come. So that's on testing technique. Now, type of sample is fixed formalin paraffin embedded. So this is another issue. A lot of patients, they have already gotten their biopsy done from another center, right? And then they tend to come to your center, and you use that same sample to do the molecular testing, and very often it comes out to be negative. That's because the preparation is very poor. So once you've taken the sample, you need to immediately put it in formalin, right, within 30 minutes. And the fixation period in formalin is also fixed. It shouldn't be too long, too less. And then you need to paraffin embed it. So in any of these processes, if there's some delay or if there's some miscalculation that's done, it can impact the chance that you'll detect a driver mutation when it's there. So your false negatives can become high. Now, role of liquid biopsy upfront. As of now, we always prefer a tissue biopsy. A tissue biopsy because it is more sensitive, and you can detect the histology of the disease and also the driver mutation. But where are you confined to using a liquid biopsy? So that is usually in cases where the patient has a very poor performance status and we cannot go for a solid biopsy. We can also consider liquid biopsy when we have already taken a solid biopsy, but the material is inadequate for molecular testing. That is very commonly seen, that the material ends up being inadequate for molecular testing. And then we can then go for a liquid biopsy. So those are some of the situations where you use a liquid biopsy upfront. So we have spoken about the workup. We've spoken about the EGFR mutation seen in lung cancer, how to detect them, how to approach it. But now let's get into treating. So treating, first we need to talk about EGFR exon 90 deletion and L858R mutations. Most of the trials for EGFR inhibitors were designed around the two most common mutations. And we're going to be talking about how we approach these mutations. So the evolution started off as first and second generation TKIs like geftinib and afatinib, then third generation TKI like osimertinib, lasirtinib. Then we started combining the first generation TKIs with VEGF inhibitors, subsequently with chemotherapy. And then currently we are in an era of third generation TKI combination therapies where osimertinib was combined with various other agents. So first we'll start off with the TKIs alone. And of course you had, the first and second, first generation TKIs first of all, geftinib and erlotinib. Now the interesting thing, mechanism of action, this geftinib and erlotinib goes and binds to both wild as plus mutated EGFR TKI domain. So so these TKIs, right? We spoke about an intracellular domain where the mutations occur. So these TKIs go and bind to that intracellular domain of the EGFR receptor. But the thing is, not only does it bind to the mutated EGFR receptor's intracellular domain, it also binds to the wild type EGFR intracellular receptor domain. So because of that, normal cells, the drug also binds to normal cells as well as tumor cells. Okay. So what is the evidence and approvals? So if you look over here, we have all these trials for geftinib and all these trials for erlotinib. Now the thing was, geftinib was discovered in the early 2000s, and erlotinib as well was discovered in the early 2000s when we did not characterize these EGFR mutations yet. As in, they were designed as EGFR inhibitors, but we did not know about the existence of exon 19 deletion or L858R substitution mutation. We were not aware of that. So we empirically, created an EGFR inhibitors, these first generation EGFR inhibitors. And in all these trials, actually, they were given in patients regardless of the mutation stages because we are not aware of the specific mutations. So all lung cancer patients received geftinib in these trials and erlotinib in those mentioned trials. Now the thing is that these numbers that you see here, if you look here, the median PFS benefit, these numbers are subgroup analysis of the EGFR mutated subgroup, and the subgroup analysis was done, many years later once we discovered these specific EGFR mutations. So these trials were done earlier on with geftinib and versus chemotherapy, or erlotinib versus chemotherapy. There was no PFS benefit seen, but certain subgroup later on were found to have responses, and the subgroup analysis showed PFS benefit. So then we went into those patients, looked at their biopsy samples, and then deciphered that these patients had specific mutations, that is exon 19 and LA58R, that led to these responses. So that's how it started. It started in these trials were done in all patients, but later on, we did subgroup analysis and detected that these drugs worked in specific mutations. Now, coming to the dose, we all know that geftinib is 250 mg OD, given before or after food, it doesn't matter. While as erlotinib is 150 mg OD, this should be given before food. Now, the toxicity of geftinib and erlotinib is easy. So you have the inhibition of wild type EGFR as well, right? On normal cells. Apart from the mutated EGFR intracellular domain, it also binds to the wild type as well. So because of that, you get rashes, you get mucositis, you get diarrhea, right? So these are all the changes that you see. And apart from that, you can also see rarely ILD. And another interesting thing is that these TKIs, they have CYP3A4 interactions. So they interact with, they're processed by the liver enzymes, by the CYP3A4 cytochrome enzymes. So they will have interactions with inducers. We know what the inducers are. They are carbamazepine, phenobarbital, phenytoin, right? So all those drugs, rifampicin, can lead to increased drug metabolism and decreased efficacy. Then you have inhibitors like azole antifungals. You have protease inhibitors. You have macrolide antibiotics. You have use of certain fruits like grapefruit. So all of that can inhibit the metabolism and increase the toxicity of the drug. So CYP3A4 interactions are important to remember. So that's it. Now another just a note about the management of diarrhea is usually managed with loperamide, mucositis, rashes, pruritus is usually managed with your steroids, as well as doxycycline can also be given. So steroid ointments and doxycycline. So coming to the second generation TKIs, you have afatinib and dacomatinib, right? So the mechanism of action here is that it's same as first gen, but stronger binding to mutated and wild type. Right. So because of the stronger binding to both types of mutated as well as wild type, you will have increased efficacy, but at the cost of increased toxicity, right? So we'll get into that later. The evidence is primarily for afatinib is from the Lux Lung 3 and 6 trial, which compared it to chemotherapy. And so by this time, we had characterized exon 19 and L858R mutations. So these trials, unlike the first gen trials, were conducted particularly in patients with these mutations. So you can see here versus chemotherapy, there's a PFS benefit. Then you have the Lux Lung 7, which looked at afatinib versus geftinib, and that showed a significant PFS benefit. And you have the Archer 1050 trial. So they tested dacomatinib only versus the first gen TKI. And so whereas afatinib showed only PFS benefit, dacomatinib is a second generation TKI that showed PFS as well as OS benefit. So that's the interesting thing about dacomatinib. Whereas afatinib initially tested versus chemotherapy showed a PFS benefit, tested versus geftinib and showed a PFS benefit only. Whereas dacomatinib showed a PFS and OS benefit. So that's the data with which it was approved. Now coming to the doses, this is 40 mg OD and is given on empty stomach. This is 45 mg OD and it is given, with or without food. So here the toxicity is increased rash, like I said, stronger binding to both wild and mutated. So increased diarrhea as compared to first gen TKIs. You have ILD, you have uh, keratitis, and you also have severe cutaneous adverse reactions like Stevens-Johnson syndrome and TENS as well. So, so increased toxicity due to stronger binding to the wild type, but increased efficacy as well due to that stronger binding to the mutated subtype. Um, Now, the thing is that once again, CYP3A4 interactions are also present here, right? So that's also something that you need to keep in mind. Dacomatinib on top of that has CYP2D6 interactions as well. So that's it about second generation TKIs. Now, this is what I wanted to get into because this is what we are going to use more and more going forth into the future. So you have osimertinib and lascitinib. So how are these different from your first and second generation TKIs? First of all, increased bindings, but increased binding to mutated, increased strength of binding to the mutated receptor. Not just that, but selective binding. So unlike the first and second generation TKIs, this, it did not bind as much to the wild type, the wild receptor. So because of that, you had decreased toxicity, right? I mean, it has a separate profile of toxicities, but your the toxicities that you derive from inhibiting the wild type EGFR receptor, like rash, diarrhea, skin reactions, were lesser with osimertinib, right? So now this is the important part. It was initially approved in the Aura trial. Now, this is something that you need to know. When you treat with a first or second gen TKI, around 60% of the patients have something called an exon 20 T790M mutation, right? And this mutation makes the patient, resistant to these first and second generation TKIs. So they needed a way to bypass this mutation, right? And that's how osimertinib was actually developed and first, tested in this particular setting. So in the second line setting, post first and second generation TKIs, uh, in T790M mutated patients, we had the Aura 3 trial, and the Aura 3 trial looked at osimertinib versus platinum plus pemetrexed, and it showed a significant PFS benefit. So it became the go-to drug post-progression with erlotinib, geftinib in those patients who had T790M mutations, which makes up 60% of that population. Then we moved it up to the first line setting, where we compared osimertinib. So this was done in those common mutations, exon 19 deletion and L858R. And osimertinib was compared with first generation TKIs, geftinib and erlotinib. And what did we see? We saw that there was a significant PFS benefit that was seen, and there was also on longer follow-up a significant OS benefit. Now, despite the significant OS benefit, if you looked at the subgroup analysis, there was the exon 19 deletion subgroup benefited, whereas the L858R group did not benefit. If you look at the hazard ratio, although this is subgroup analysis, it's 1. So the benefit was less distributed or less seen in the L858R mutation subgroup. So that was something to ponder about moving forward. But for all intents and purposes, it showed a PFS as well as OS benefit over first generation TKIs. And so it became the standard of care upfront setting for exon 19 deletion and L858R mutations. So now this is something that I want to get into a little bit more in depth. So you tend to see a little bit of rash, mucositis, diarrhea, but these are generally rarer as compared to first and second gen. It's not like it's not seen, but it's relatively rare. Apart from that, these are important things that you need to look at. You need to do a baseline ECG and look at the QTC interval, right? And the baseline, it should be less than 450. During treatment, if it goes above 500 on 2 readings, then you stop the drug and restart when it is above 480, right? But if this, if on stopping the drug for a maximum of up to 3 weeks, if it does not fall to below 480, then you might have to think of discontinuing the drug. Or if QTC prolongation leads to severe symptoms, then you might think of discontinuing the drug. But usually, if it's more than 500, you take 2 readings, you wait till 2 to 3 weeks, and once it falls less than 480, you restart the drug. Another thing it can cause is cardiomyopathy. Although this is rare, less than 5%, but you take a baseline echo as well to look at the cardiac status beforehand. Now, another thing is ILD, seen in less than 5% of patients, but once it occurs, we generally tend to discontinue the drug. Another thing that's seen is aplastic anemia. I'm telling you all this stuff in depth, even though it is rare, because we are going to be using this drug moving forward. So this is something that we need to be well acquainted with. So aplastic anemia is less than 1%, but once it happens, confirmed with the bone marrow, you stop the drug. Then you also have cutaneous vasculitis and even more serious side effects like Stevens-Johnson syndrome and TENS, right? And another toxicity that you have is keratitis. So these are the toxicities that you look out for. Although rash, mucositis, and diarrhea, they're seen, but lesser than first and second generation TKIs. QTC prolongation is seen. Cardiomyopathy can be there. ILD can be caused. Aplastic anemia, cutaneous vasculitis, severe cutaneous adverse reactions, and keratitis. So these are some of the toxicities that you commonly tend to see. These ones are rare, but your rash, mucositis, diarrhea, although lesser, it is there. So it is generally a very safe drug to use. If you have seen it on a practical level, you would have noticed that patients complain of less toxicities. Now, we spoke about all this, but there are certain groups where we were not really getting good outcomes. Earlier, I alluded in the FLORA trial too, EGFR and 858 are having poorer outcomes. Other groups like patients with brain mets, TP53 mutated, liver mets, etc. These groups generally tend to have a poorer prognosis. So the idea was, okay, how can we improve outcomes in these groups with EGFR inhibitors? So that's what led to combination therapies. So initially, they combined other drugs with first generation EGFR TKIs. So the first modality of combination was erlotinib with a VEGF inhibitor. So basically, the idea was that you could enhance TKI delivery to the tumor by combining it with a VEGF or a VEGFR inhibitor. So they had 2 trials, NEG-026 and Relay trial, which looked at erlotinib plus bevacizumab versus erlotinib alone, and erlotinib plus ramucirumab versus erlotinib plus placebo. Bevacizumab is a VEGF inhibitor, and ramucirumab is a VEGF receptor inhibitor. So both these trials showed increased PFS over erlotinib alone, significant. And not just that, but it showed benefit in the L858R group as well. So possibly, if you get an L858R mutated patient, this is something that you can think of, combining it with a VEGF inhibitor. That we do not see that benefit with osimertinib alone, actually. Now, the next thing was trials looking at combination of geftinib plus chemotherapy. The rationale was that TKI decreases the thymidate synthetase level, and we all know that pemetrexed is used in. So the chemotherapy here was carboplatin plus pemetrexed, and we know that based on last class, we know that pemetrexed inhibits thymidate synthetase. So this TKI decreases the level of thymidate synthetase, so it can enhance the efficacy of pemetrexed. So that's why you can combine geftinib plus carboplatin plus pemetrexed. So that is the rationale. So both these trials, the Tata trial and NEG009 trial, they looked at TKI alone, that is geftinib alone, versus TKI, that is geftinib plus platinum doublet. So they would give 4 cycles of platinum doublet plus TKI, and after establishing a response, they would then continue with the TKI and pemetrexed maintenance, right? So both these trials looked at that, and the Tata trial had PFS as well as OS benefit, and the NEG009 trial had PFS benefit. So that also became another option. Now, the obvious step, right, to take it forward is combining it with a third generation TKI. So third generation TKI combinations was the next step in the evolution of the treatment paradigm. And this is something that was presented recently at ASCO 2025 and the World Lung Cancer Congress. So this is fresh out of the oven, where they looked at osimertinib versus osimertinib plus pemetrexed plus carboplatin for 4 cycles, followed by maintenance with osimertinib and pemetrexed, right? So in first-line setting, in exon 19 deletion and L858R mutated patients. So what did we see? We saw a significant PFS benefit here, 25.5 months and 16 versus 16.7 months. And if you look here, this benefit was seen regardless of the EGFR mutation type, that is L858R also benefited. And the most beautiful thing here is that, like you said, brain mets is one of the poor prognostic factors. The patients with brain mets also had excellent outcomes. In fact, the PFS is around 25 months, which is similar to the overall group when it came to brain mets. So combining chemotherapy plus osimertinib upfront showed a significant PFS benefit that was also seen in these traditionally poor prognostic subgroups. Not just that, it didn't stop there. It also showed at 4 years, recently presented, a significant OS benefit of around 8% absolute OS, right? So, that was significant. And this was seen over single agent osimertinib. So, I mean, it then, that makes it, a new treatment, a new standard of care, right? It can now claim its right to being a new standard of care. The combination of osimertinib plus carboplatin plus pemetrexed. So that's what happened with the FLORA-2 trial. Now, coming to the toxicity, of course, when you combine osimertinib plus chemotherapy, you would worry about the toxicity. But the main toxicity here is myelosuppression, obviously, with the chemotherapy. That's what we would expect. And that's what we saw. The higher grade toxicities were generally myelosuppression. And it led to a lot of treatment discontinuation. So, we give 4 cycles of carboplatin plus pemetrexed and followed by pemetrexed maintenance. But around 50% of the patients discontinued pemetrexed. But despite this discontinuation, we still saw that OS benefit, which shows that, even with dose discontinuation or interruptions, you still, got that OS benefit, which means that initial chemotherapy you give with osimertinib, those 4 cycles of carboplatin plus pemetrexed, is what is doing the trick. And the toxicity, actually, if you look at it, so like I said before, patients received generally 4 cycles of platinum as per protocol, and pemetrexed was discontinued in 50% of the patients around after 8 months of use, but osimertinib was generally continued. So although like we said, toxicity is there, but it is front loaded with osimertinib and platinum doublet. So we need to counsel the patients that yes, you will see increased toxicity, but it's going to be front loaded. And even if we have to discontinue the drug, you'll still get the benefits. So those are the 2 points you need to think about when you talk about the toxicity of FLORA-2. Now, the next combination is based on the Mariposa trial, which looked at amivantamab plus lacetinib. Lacetinib is a generation 3 TKI, just like osimertinib, and amivantamab is a bispecific monoclonal antibody that is it targets MET as well as EGFR receptor. So unlike the TKIs, which bind to the intracellular domain, just like as you can see here with lacetinib, which is the 3rd generation TKI, amivantamab is bispecific. So it binds to 2 receptors on the extracellular domain. So it binds to EGFR and it binds to MET. MET was chosen as the second receptor because a lot of patients who progress on EGFR inhibitors, they have MET resistance, as we'll talk about later. So that is why this bispecific was designed to target both EGFR and MET on the extracellular domain, unlike the TKIs, which bind to the intracellular domain. So you had amivantamab plus lacetinib, and that was compared with osimertinib alone, right? What did we see? We saw a significant PFS benefit, and not just that, we saw a significant OS benefit as well. In fact, the OS is still not reached. And this benefit was seen once again in almost all the subgroups, right? So I'm not going to talk about the toxicities of amivantamab today. That will take a separate class for that. That's an important drug altogether. But looking at this currently, you can see here that both these drugs, both these combinations, Mariposa with amivantamab and lacetinib, and Flora2 with chemotherapy doublet plus osimertinib, these had, you know, unlike the osimertinib alone or the previous first and second generation TKS, it showed benefit in all the poor prognostic groups. L858R, yes, brain mets, liver mets, TP53 co-mutation. And something else I looked at was baseline ctDNA positivity for EGFR, right? If it could be detected in the plasma. Even in those patients which generally tend to have a poor prognosis, both these combinations worked. So now the question is, I've spoken about TKIs alone, first, second, third generation. I've spoken about combinations of first generation TKIs with VEGF inhibitors, with chemotherapy. I've spoken about combinations of third generation TKIs with osimertinib plus chemotherapy, or lacetinib plus amivantamab, which is bispecific monoclonal antibody. So what should we do as of now? So as of now, the current standard of care is either osimertinib plus platinum plus PEM, or it is amivantamab plus lacetinib. Both these trials, both the Flora2 trial and the Mariposa trial, showed OS benefit over single agent osimertinib, and currently, the world over, this is the standard of care, right? So what about all these other combinations that we spoke about? So first, osimertinib alone, what is the role of osimertinib alone right now, given that these doublets with osimertinib are the current standard of care, since they show an OS benefit? So patients who cannot tolerate the combination therapy with poor PS comorbidities, we can give single agent osimertinib for those patients. For patients who have an exon 19 deletion, so we know that exon 19 deletion tends to do better than L858R, and they don't have any other adverse risk factors like, for example, liver mets, brain mets, TP53 co-mutation. Those patients can still be considered probably for osimertinib alone, and also based on patient preference. So some patients might, despite the OS benefit, they might want less toxicity. So in those patients, we can consider osimertinib alone. What about the OG treatments? So we have first and second generation TKIs. We have geftolimab in combination with chemo, erlotinib in combination with antigenic agents. What about these combinations? What role do they play currently because of all these advances? So affordability and logistics, these are still the go-to regimens in lower middle income countries. This is what we generally tend to use in our OPDs even now. And it'll be some time before we can, go to the third generation TK combinations and those drugs on a common basis. So once again, the use of TKI alone, first or second generation, versus combination is based on the CNS disease. CNS disease, we might think of combination, mutation status. L858R, we might think of erlotinib with angiogenics, as we saw earlier. Those patients tend to benefit more. Presence of co-mutations, TP53, we might go for combination. Symptom burden, if the patient is highly symptomatic, we might go for a combination with chemo. Patient performance status, if it is poor, we might go for single agent rather than combination. And comorbidities can push us towards single agent. So LMICs, even though the standard has moved out to doublet, we still go ahead with these drugs because of affordability and logistics issues, right? Now, treating exon 20 insertion mutations. I said that the third most common type are these exon 20 insertion mutations. So these are generally, they have inferior outcomes and they have resistance to all TKIs. So that is, it sounds very scary, but the interesting thing here is that there are two types of exon 20 insertion mutations, and this is some advanced knowledge, but I think you should know this. So you have a C helix here, right? You have a C helix and you have a post C helix. So the post C helix makes up around 90% of the exon 20 insertion mutations, and the C helix makes up around 10% of the exon 20 insertion mutations. Now, the interesting thing here is that the post C helix mutations are generally resistant to TKS, whereas the C helix mutations tend to still show sensitivity to TKS. So when you see an exon 20 insertion mutation, you should not right away say, okay, TKS won't work. You should look at whether it is C helix or post C helix, and based on that, you can see whether, although C helix is very rare, but still you should be aware of this. C helix still TKS work. Majority of the mutations are post C helix; their TKS don't work. So the question is, how do we treat? Simple. We have the Papillon trial currently, which is amivantamab plus chemotherapy. That is now the standard of care, versus chemotherapy alone, which is the earlier standard of care. This has shown a significant PFS benefit. And so amivantamab plus chemotherapy is the standard of care based on the Papillon trial for exon 20 insertion mutations. So I won't linger there too much. Now, treating rare mutations, right? G71X, exon 20 S768I, and exon 21 L861Q. So these are some of the rare mutations that we tend to come across. And here, generally, we have afatinib. So this is the only, afatinib is the only drug where we have a phase 3 trial for these, specifically for these mutations, which has shown a PFS benefit versus chemo, right? We also have various phase 1 and 2 trials, which has looked at TKI plus chemo combinations as well. But generally, afatinib is the most commonly used drug. We can also give like geftinib plus chemo or osimertinib plus chemo, but the data is more limited. It's usually phase 1 and phase 2. Phase 3 data is for afatinib. So that's how we treat those rare mutations, particularly these 3 mutations. Now we come to the interesting stuff, right? Patient presents with, now this is what's going to help you in your practice. So patient presents with upfront diffuse brain metastasis. What is the role of WBRT, whole brain RT, in this scenario? What are the practical issues faced while making a decision regarding WBRT? So the patient comes, you're sitting in the MDT, the radiation oncologist is take him up for WBRT. I mean, that's their go-to reflex, right? But then the issue is that, why should we do WBRT? If you look at the data, right? If you look at osimertinib alone, it has an overall response rate of 87%, right? If you look at osimertinib plus chemotherapy, it has an overall response rate of 88%, with a PCR rate, with a CR rate of almost 50%, with a median PFS of 25 months. So with these combination therapies, right, you have excellent median PFS, you have great overall response rate, and you have even high CR rates. Like with osimertinib plus chemo, it's 48%. So the question is that, and one more thing to add is that in these trials, like Flora 2 and Mariposa, they rarely use WBRT in SRS. Because it was not needed, because you had such great response in the CNS with these combinations, even with single agent osimertinib. So with these newer treatments, unlike first generation, second generation TKIs, which have very poor blood-brain barrier penetration, osimertinib and especially osimertinib combinations have excellent responses in the brain and great PFS as well. So we know that WBRT can cause neurocognitive effects. This is unacceptable considering we are now approaching around 5 years of survival with EGFR mutant non-small cell lung cancer. So we can omit it in most patients. It can be considered for highly symptomatic patients, example, patients with impending herniation or patients not responding to steroids. And even in these patients, when we are doing WBRT, we need to do techniques like hippocampal sparing WBRT, SRS, or fractionated SRT, etc. So for the most part, we have pushed aside WBRT with these new regimens, with these third generation TKIs, which have high blood-brain barrier penetration with great responses. And it should be used sparingly. And when used, we should use highly selective techniques to prevent neurocognitive decline. Tangent scenario 2. Patient is highly symptomatic while awaiting NGS report. This is a very common scenario. You got the patient, now the patient is highly symptomatic. You've sent NGS, you don't know about whether it's EGFR mutated or not. But you get, before NGS, what do you get quickly? You get the IHC report. And through IHC, we do PDL1 testing. And the TPS score is 80%. You're like, oh, I mean, you might have heard about this Sanjay Dutt, who had a PDL1 score of 60%. and was treated with, he had stage 4 lung cancer. He was treated with, carboplatin, pemetrexed, and pembrolizumab 4 cycles, then pembrolizumab for up to 2 years. And it's been more than 5 years. He's completely fine. So, looking at that TPS score, you're like, okay, I think we should start on chemotherapy and immunotherapy, your checkpoint inhibitors. But is that really wise? Because what we tend to see is that you should actually, it's more prudent to wait for your NGS report. I'll tell you why. Because if you start on an immune checkpoint inhibitor, later on, when you want to switch, when you want to add a TKI, what happens is that around 15% of the patients develop severe immune-related adverse effects, like pneumonitis, colitis. In fact, we have seen it in one patient, severe pneumonitis, and the patient died, in fact. So, this is something you need to keep in mind. When you're not received your NGS, just based on the PD-L1 testing, you should not start off on immune checkpoint inhibitors. Start off on chemotherapy, since the patient is symptomatic. And once you've received your NGS and confirmed that there's no EGFR mutation, then you add the ICI. Because if you add the ICI earlier on, you cannot switch to a TKI. Within the first 3 to 6 months after giving an ICI, if you switch over to TKI, you'll have severe immune-related adverse effects. So start off with chemotherapy alone in such patients while awaiting results. Very important point to keep up in your mind. So now the tumor progresses. What is your next step in the workup? This is something that, we face. The thing is, do a repeat biopsy, right? Because there's a mechanism of resistance that's leading to progression. We need to see what is that mechanism of resistance. And this is a very common question. I think it was asked in the recent DNB exam. And something that you need to know. It is a very relevant and modern situation that we're facing. So what are the types of resistance mechanisms seen post-therapy with EGFR inhibitors? So you have EGFR mutation amplification, which is an on target. So it can affect the EGFR receptor. This could be mutation amplification. It could be an other mutation in the EGFR receptor, like you see 797S. So excuse me. I would like to mention here that these are the mutation profile that we see post osimertinib. I spoke about post first and second generation TKI. It is most commonly T790M. I'm talking right now about the mutation profile post osimertinib. So most commonly you have on-target mutations or the rest off-target mutations. So on-target mutations can be EGFR amplification, other mutations in the EGFR intracellular domain, right? Then you can have off-target mutations. This can be bypass signaling activation. So other pathways like MET, most commonly, HER2, FGFR, etc., can be activated. You can have downstream pathway activation. So you can have RAS, RAF mutation. You can have a PTEN mutation, right? So all these downstream, pathways can be mutated. Or you can have, you can have EGFR on target, you can have off target other receptors or downstream mutations. You can have cell cycle related mutations, like in your CDK4/6, etc. And 10 to 15% of the patients, you can have a transformation to small cell lung cancer. So that is also commonly seen, actually, 10 to 15% of the patients. So these are the different pathways, on target and off target, and histological transformation, right? So how do we proceed here? So generally what we can do is, this is one scenario where you can combine a tissue biopsy and plus a liquid biopsy. Because unlike a treatment naive patient, a patient who has been treated with a TKI or a TKI combination, they will then tend to have heterogeneity between the lesions. So the new lesions might have the mutation, whereas the older lesions or other particular lesions might not have the mutation. So by liquid biopsy, you can account for the tissue heterogeneity that is seen on progression, unlike treatment naive patients. So this is what you can generally tend to do. And here we are also guided by the VAF, which is variant allele frequency. So that is, if you take a particular 100 cells, the number of cells that show the mutation or the frequency which the mutation is seen amongst the tumor cells is the variant allele frequency. So suppose you get a MET mutation and you get a HER2 mutation. Both these are seen on your NGS report, right? So if the MET mutation has a VAF of around 50%, whereas HER2 has a VAF of around 2.1%, definitely we can say that the MET mutation, the MET amplification is the predominant driver resistance pathway, right? So that's how you look at it. Combined tissue plus liquid biopsy, look at the VAF to guide your treatment. Another thing is, here, earlier I spoke about hotspot NGS and hybridization capture NGS. This on progression is a good time to do a hybridization capture NGS, because those 12 genes that you look at, that's not enough, because you might have other resistance pathways. So you need a wider profile. So a hybridization capture technique, for example, Foundation CDX, which looks at around 312 genes, is more logical to use in this setting, right? So combine liquid, tissue, look at the VAF to guide your major resistance pathway. Another thing is, how do you tackle oligo progression? Suppose, say, you have, all the lesions are under control, but you see new liver lesions, 2 new liver lesions. Do you switch the TKI? Not necessarily. So if the disease has progressed in only a few sites, say less 1 to 5 sites, and those sites are treatable with local treatment, then we can consider continuing the TKI and giving local treatment. Local treatment could be in the form of, say, liver mets, could be in the form of SBRT, could be in the form of resection of the metastatic disease. So if you're able to give local treatment and the progression is confined to just 1 to 5 sites, then you can continue the TKI along with local treatment. So oligo progression, continue the TKI, give adequate radical local treatment to the progressive sites only. So that is what we do nowadays. Now, treatment in the later lines. So suppose you're given your post third generation TKI. We know that 50 to 60% of the patients who progress on third generation TKI, we're talking specifically post third generation TKIs, they tend to have an identifiable resistance mechanism, which is why we do that biopsy and all that natak, on progression. So these can be treated. We're just about to wind up now, so we'll just quickly, get this over with. This is very important. There can be a targeted approach to treatment and a non-targeted approach to treatment. So targeted approach, right? So if you have a particular targeted resistance profile, suppose a trans C797S mutation, you can actually give a first, second generation anti-EGFR TKI, right? So this is one of the scenarios where you're treating the patient based on an osimertinib-based regimen. You develop the trans C797S mutation, you can add a first generation TKI and it will have response to that. So it's actually magical. I've seen a patient like this who progressed after 4 years on osimertinib, and we started the patient on geftinib along with osimertinib because they had a trans C797S mutation, and the patient is did well for another 1.5 years. So if it is a cis C797S, you can give cetuximab plus brigatinib, or if it's a MET amplification mutation, you can give osimertinib plus a MET inhibitor, or you can give something called chemotherapy plus amivantamab, because we know that amivantamab also inhibits EGFR and MET. It's a bispecific monoclonal antibody. If you have small cell lung cancer transformation, so you give a targeted approach, you give platinum plus etoposide, specific for small cell lung cancer. Now, non-resistance targeted approaches. So we are not identified as a particular resistance mechanism, but we have other approaches. So what can we do? We can give chemotherapy plus anti-VEGFR. So example, docetaxel plus ramucirumab based on the REVEL trial. We can give chemotherapy plus anti-VEGF plus anti-PD-L1. So this is one setting. It's called the ABCP regimen, atezolizumab, bevacizumab, carboplatin, and pemetrexed. And it's been shown in the IMpower 150 subgroup analysis and Atlas trial that even if it is EGFR mutated, normally ICIs don't work for driver mutations, but when you combine ICI, bevacizumab, and chemotherapy, post-progression in EGFR mutated patients, it tends to show a PFS benefit. And we have data for that. Then you have chemotherapy and amivantamab. There's something called the Mariposa 2 trial in post-osimertinib progression, and chemotherapy plus amivantamab had a PFS benefit over chemotherapy alone. You also have anti-HER3 targeting ADCs like patritumab deruxtecan based on the HERTHENA TRUE trial. So these are some of the non-resistance targeted approaches to treating progression post-osimertinib based therapy. The summary: combination therapy, third generation TK is the current standard of care in EGFR mutated metastatic non-small cell lung cancer. Selection depends on multiple adverse factors in addition to side effect profile and patient preference. Osimertinib monotherapy. So generally, we tend to give osimertinib plus chemotherapy or lastinib plus amivantamab. That's the standard of care now. Osimertinib monotherapy can still be considered in certain low-risk groups or poor PS or patients with poor PS or cohorties. First and second generation TKI-based therapy still plays a pivotal role in lower middle income countries, and rebiopsy is absolutely necessary. This is very important on disease progression to facilitate appropriate therapy. Thank you. I hope you had a great class, and I hope you understood what I said. If you have any questions, please post it in the chat, and I'll get back to you on WhatsApp.